I would like to tell you about a study that we presented at this meeting that evaluates the worth of using Daratumumab upfront in combination with Lenalidomide and Dexamethasone, as opposed to VRD, in patients who are transplant ineligible. Now, it should be said, both regimens have been accepted by the Mayo guidelines recommending treatments for patients who are transplant ineligible in the United States, MSMART and CCN. But we wanted to know what might be a better choice, and we did a simulation which goes as follows. First of all, we look at the Maya study, and we look at the data from the Maya study that has shown significant improvements in progression-free survival and overall survival, and that has been published. Then we looked at the SWOG study, and the SWOG study has been a reference study that compared again the triplet VRD versus RD, which shows the superiority of the triplet with improvement in overall survival in the intention to treat population. However, as one looks at patients who are over the age of 65, there appears to be no difference. Now, when you think about the choices, we have a conundrum because we have great data for the treatment of that first relapse with regimens like Pollux. Pollux is Daratumumab, Lenalidomide, and Dexamethasone versus RD. What happens is you can't extrapolate from Pollux because patients in Pollux are younger by about a decade of what you see in Maya. And they're also enriched for more fit patients. In fact, 60% of them had a prior stem cell transplant. So we wanted to do the simulation in the following way. So we took the data from frontline therapy from Maya for DRD and RD. We look at the Flatiron Health database for RBD, although we did this as well too with the SWOG study, and the results are exactly the same. Then we introduce a step that is critically important, and that is that of attrition. Our group has published, and others have published, that with every line of treatment, there's a percent of patients that just cannot move on, cannot complete the subsequent line of treatment. And we took a whole range of an upper boundary and a lower boundary. The upper boundary is the current one for Maya, which is on the high side. The lower boundary is 27.2, which excludes the sensor patients. Now, 27.2 attrition is actually low. In our publication, it was up to 50% per line of therapy. So let's go with 27. And what we did is then we look at the use of regimens that could rescue any one of those initial therapies. So if you start with Daratumumab, then your first line for rescue or first relapse would be either carfilzomib or pomalidomide. And if you start with RBD or RD, then we said you should look at Daratumumab. So we look at, again, real-world data sets from the Flatiron, and with that, then we could create some calculations. And the bottom line is what we found is that if you start with DARA-RD and then followed with carfilzomib and pomalidomide using this real-world data, you have a median overall survival of about 9.1 years. For the transplant ineligible, which is in and of itself remarkable, but importantly, it's 2.5 years longer than with RBD and about 3.5 years longer than with RD. And once more, again, we ran all the range of the various attritions, the results did not change. So what I present in this paper and what we conclude is that using DARA-RD seems to be the best choice for patients with frontline therapy. And I say parenthetically, which I don't really address in the analysis, but you're looking at the regimen that has no peripheral neuropathy. And with a simulation like this, we say, I think the choice is clear. The question could come up, what about those patients with high-risk disease? And there's a couple of answers there. Number one is high risk is less common in the elderly. It's more like 10 to 15% as opposed to 25, 30% in the younger. And then there's emerging data that drugs like Daratumumab and others like Selinexor or Isatuximab, others might be able to overcome some of those high-risk markers. So I don't think that's a major consideration. So in my opinion, this really sets the stage for this being the preferred regimen. Again, this starting from the point that both have been accepted by all guidelines.